Hello, everybody. Just wanted to welcome everybody that's coming in today. Thank you for being with us. We want to welcome Dr. Monroe-DeVita. We will get started in about a minute or so. Okay. And I just want to say that my name is Kara Jacobson, and I'm the manager of the Center of Excellence. And thank you all for joining us today. And thank you, Dr. Monroe-DeVita and our panelists for their time. And for anybody who's looking for CEUs or certificate of attendance, please fill out the survey that we will be putting in our chat so we can confirm that you have participated. And if you cannot connect to that survey, if you could just enter your name and email into the chat, that'd be great. And feel free to enter any questions that you have that you'd like for us to answer into the Q&A, which is separate from the chat at the bottom. Our panelists or Dr. Monroe-DeVita can answer in our Q&A portion, and we'll get to that later on after our panelists and Dr. Monroe-DeVita have spoken. And we really look forward to you all enjoying us today. I just want to introduce Dr. Gary Morse, the Director of Center of Excellence today. We will be getting started shortly.
Thank you, Kara. I also want to welcome everyone to today's Center of Excellence webinar on current trends in ACT research and practice. And Center of Excellence is a new program at Places for People. And for those of you who may not be familiar with the center, a quick thumbnail of background information. Looks like the video was off. Sorry, got that back on. Just a quick thumbnail of background information. The mission of the Center of Excellence is to promote high quality behavioral health systems that increase the use of recovery-oriented evidence-based services that improve access and human well-being. The major activities of the Center of Excellence include trainings, webinars, and conferences like this one today, and particularly given the pandemic, we're making greater use of the webinar platform, agency consultations, intensive coaching, mentoring, and technical assistance to really help providers build their skills and ability to change and deliver the recovery-oriented evidence-based practices, system advocacy, and community education. One of the most critical services for people in a recovery-oriented evidence-based mental health system is that of assertive community treatment, or ACT. As you might know, ACT is one of the oldest, most widespread, best researched, and most effective community-based services for people with severe mental illness, especially for those with high levels of service needs. Today, we're very fortunate to have one of the leading national and really international experts on ACT, Dr. Maria Monroe-DeVita. Maria first started her work on ACT about 20 years ago while she was earning her Ph.D. in clinical psychology from the University of Nebraska, when she conducted an evaluation of Nebraska's ACT programs. After earning her doctorate, Maria continued her work on ACT, first working with the state of Utah on ACT program development, at which time she also worked closely with Debbie Allness. Debbie, as you may know, was the team leader of the original ACT system, which was in Madison, Wisconsin, and among other things, including the commissioner of mental health there, the co-author of the classic book put out by NAMI on how to start up ACT teams. After joining the faculty of the University of Washington, Seattle, where Maria is now associate professor in the Department of Psychiatry and Behavioral Sciences, she took lead responsibility starting in 2006, 2007 for the state of Washington as they embarked on an ambitious program, statewide program, to develop 10 new ACT programs across the state. Since then, Maria has helped develop and train an additional 8 AC teams in Washington, so a total of 18 there now. Maria says there's actually plans to go up to 22 in the next year or two. And she's worked with a number of other states for starting up, training, and improving their local ACT teams. In addition, Maria has conducted training and consultation internationally on ACT, including in Denmark, Norway, and China. Her training work is extensive, but perhaps Maria is best known for developing with her colleagues Greg Teague and Lorna Mosier the tool for measurement of ACT fidelity, also known as the TMACT. The TMACT has become the predominant tool for measuring AC fidelity. It's now used by a large number of states, is considered the gold standard, and those states include Missouri, where Maria helped train state staff in Missouri, as well as in a number of other states and in other countries. Maria's work with the TMAC has not simply been to evaluate fidelity, though that is certainly important, but she's also pioneered the use of the TMAC to guide follow-up training and technical assistance to support ACT quality improvement efforts to bring teams to their highest levels of performance and excellence. While Maria has focused much of her time on ACT developed training and evaluation, she is also an accomplished researcher, having published more than 30 articles on ACT and in other areas like burnout prevention and services for people and families experiencing first episode psychosis. There's a lot more that I could say, but at this point, let me suffice to acknowledge that Maria's unique combination of experience and skills makes her a leading global expert on providing effective and recovery-oriented ACT. I also want to say that I've been blessed to know Maria for the past 14 years as a valued colleague and as a friend, during which time I've been privileged to witness that Maria is not only a talented and dedicated mental health professional, but also an individual of great compassion, kindness, good humor, and good cheer. We're very fortunate for her to be here today with us to share her expertise in the middle of this challenging and turbulent period in which we are living. And we're also so glad that all of you have carved out time to consider the most effective way that we can help serve people with mental illness. So without further ado, I'd like to welcome Dr. Maria Monroe-DeVita. Dr. DeVita.
Wow, Gary, thank you. It's quite a humbling introduction. I appreciate all of your kind words. And I don't know if it was clear to everybody watching today, but just to be like perfectly clear, and I think this kind of helps kind of to provide a segue at least into my second slide here. Let me just get you guys see my slide deck okay?
Yep.
Is, Gary, the fact that you're the one that I give the most gratitude to in helping to launch the work that I've done in ACT. For those of you who don't know, we wouldn't have ACT in Washington State if it weren't for Gary, and the fact that he picked up his phone on a very dreary but very typical Seattle day here during a winter break when I was desperately trying to figure out kind of who we were going to have come here from the national perspective to help us to launch our teams. And Gary graciously not only accepted, but I don't think he realized that he was going to be spending most of his summer of 2007 in Washington State, driving all over to get things started here. So I am very grateful to you. And also my friends and colleagues at Places for People. I feel like this is a little bit of old home week, if you will, to be able to be here presenting and to be, seeing people like Julie and Don Shipp and, Lori Norval from DMH, who I trained in the TMACT, to, kind of have us all here together and to talk about some of the work that we've done together over the years and also think kind of ahead to the future. I also wanted to acknowledge and give huge thanks to my colleague, Lorna Moser. She gives proper credit. She's at the University of North Carolina at the Institute for Best Practices. She and I are essentially kind of joined at the hip when it comes to ACT stuff. She's my co-author on the TMACT, and we collaborate on many projects and trainings together. And many of these slides represent those projects and presentations that we have done collaboratively. So great thanks to her in kind of helping to launch our work today. All right, so today I'm going to talk about, first of all, just getting us on the same page to talk a bit about ACT, what it is, and probably even more so about what it is not, because there are a lot of misconceptions out there. Current challenges within ACT. So when we talk about sort of the trends in research and treatment, I'm going to kind of frame them within sort of current challenges that we're facing within the field, within a sort of community treatment, but also some possible solutions to address those challenges. And then I would be remiss if I didn't actually sort of go into the belly of the beast here and talk about COVID and kind of how it's affected teams and some of the things we've been seeing, some of the successes, some of the strategies the teams are using, and hopefully we can identify some best practices out of what we're presented with right now. And then a little bit about the future of ACT and kind of where I see things going and where we can be moving together as a field. And I think after we'll shift over to a panel presentation and some questions and answers. Gary, is there I won't be answering questions during, correct?
That's right. What we were hoping to do would be for you to do the presentation and then have kind of the remarks and the comments by the panel. And then after that, have a dedicated time for questions and comments to you as opposed to the other panelists. So.
Perfect. All right. So, well, why don't we go into, before we get into the ACT trends, I do want to get us all on the same page about ACT, both what it is and, as I said earlier, potentially, most importantly, what it is not. So for those of you who don't know, it's important for us to maybe start a little bit with its beginnings, because I think that kind of helps to sort of illustrate kind of where we are today in terms of the targeted outcomes that we were previously measuring and why those were important. So ACT originates out of the early years of deinstitutionalization at Mendota Mental Health Institute, which is still there in Madison, Wisconsin. It's one of the state hospitals in Wisconsin. At the time, inpatient providers were observing that while they were able to successfully treat patients served on the unit, they were often readmitted back to the inpatient unit. That kind of revolving door phenomenon was kind of full in force. And what they found was that people were left to manage a pretty fragmented mental health system for themselves. Remember, this wasn't that many years after JFK signed the Community Mental Health Act of 1963, so there was a lot they were still working out in those early years of community mental health. And it was pretty clear to the group that there was something right about kind of how services were delivered on the unit, and then it wasn't just because people were kept in a secure setting. So researchers, Leonard Stein, who it was a psychiatrist, and Marianne Test, a psychologist, essentially decided to kind of take that mix of intensity, services and supports, and the multidisciplinary staffing that kind of goes along with that, and transferred it all into the community. And lo and behold, results showed that it worked, particularly when it came to reducing rehospitalization. Later, I'll kind of get into some of the data just briefly about sort of, again, those outcomes, because again, knowing those outcomes about ACT is really important for us to kind of keep our eye on where we want to go for the future. So I'll just kind of put that out there as a little foreshadowing. But again, therein is really where ACT was born. They called it PACT at the time, and they still call it PACT, so Program of Assertive Community Treatment. Here in Washington State, we call it PACT as well, kind of to pay homage to that original model and kind of keeping to the fidelity of the program. So let's talk a little bit about some core features of the program. It is an evidence-based practice for adults with serious mental illness who really represent those in greatest need due to the severity and persistence of their mental illness. So diagnostically, this is a group that typically includes those with schizophrenia spectrum disorders, as well as affective psychosis. They can also experience significant challenges with maintaining day-to-day role functioning in many aspects of their lives, such as securing or keeping a job or a home, or maintaining basic health needs or social relationships, kind of all of which are the hallmark of many of these illnesses. And then lastly, they are typically individuals who have not benefited from or have had a tough time engaging in traditional outpatient services and experience what we call continuous high service needs, which means they've been, in and out of acute inpatient units or longer term state psychiatric hospitals, or have had multiple admissions to crisis services or high ED use or criminal justice settings. And then about half to 3/4 of this group also experiences challenges with co-occurring substance use. All right, so then ACT relies on this team-based approach. You heard a little bit about it as I talked about the Madison model, and again, thinking about a typical inpatient unit with that multidisciplinary team. So that means that team members know what is happening with every single client served by the team, and they have mechanisms in place to kind of make that work out. Because it is a multidisciplinary team, they have the capacity to directly provide a range of services and don't broker to other programs, as is common among traditional case management programs. Like when I was a case manager, I remember sort of that was my job, was to connect people to different resources outside of that. For example, each team has a co-occurring disorder specialist, and their focus is on delivering integrated stage-wise substance abuse treatment versus referring out to a substance abuse treatment provider. Or similarly, the team peer specialist, who is a person with their own lived experience with mental illness and trained to deliver peer-based services. They're the ones then that spearhead the delivery of wellness management approaches such as RAP and other models. ACT is not office-based. Services are provided in the homes and communities of the people served by the program. And the reason for this is not only to ensure that people don't fall through the cracks, especially given that many people served by ACT have faced challenges around engagement and services, but also to ensure that there are opportunities to practice and really try out skills in the very settings in which they would be directly applied in the community itself, and where people are living and working and engaging in social interactions with others. That's the goal, that's the key. ACT teams also have the capacity to provide services at a high level of intensity and frequency, which requires a lot of flexibility in kind of how, when, and where they're provided. On average, this is kind of the Fidelity standard, if you will. Across the team, this comes out to about 3 face-to-face contacts per week per client, and an average of about 2 hours of face-to-face contacts per week per client. And again, that's an average. So some people receive less and some people receive more. And the point is to really individualize those services. But again, recognizing kind of who we are focusing on providing those services for, we kind of aim for those numbers and assume that there is a need for that. A big misconception of ACT, and you'll hear me say this over and over again in today's talk, is that it's only a case management model, and that many of the services kind of entail doing for the people served rather than teaching them to do for themselves. But case management is only one of several comprehensive services an ACT team should offer. I mentioned earlier sort of integrated dual disorder treatment, employment services in alignment with the individual placement and support model, or IPS model of supported employment. Those of you who listened to Bob Drake's talk last month, he talked a lot about that model. CBT informed care, just to name a few. And just to kind of further illustrate this point, you can kind of see here that there is a mix of kind of different types of treatment, outreach and engagement services, psychiatric rehabilitation, including skills training, and then support. So really kind of that case management I talked about earlier, it's only one part of it. And yet, it's pretty common for people to think that that's kind of what the model is all about. And it's really just sort of this one piece of it. The exciting part, I think, about what you see in front of you too, is just that this is truly sort of the way that the model has evolved, that it allows for, it is a platform in a sense for which services can be delivered. Other evidence-based practices can be integrated and applied, like individual placement and support for supported employment practices. So I think that's what's really cool about it, and you'll hear me talk about that theme as we continue on the talk today. Further, while the team should be assertive, obviously, in its approach, this should never mean that they're coercive. So strengths-based assessment, person-centered treatment planning, and related recovery-oriented practices that really promote self-determination and independence are key. And I think that also kind of interplays with that sort of skills teaching component of what ACT teams do. Let's talk a little bit about the outcomes within ACT. So ACT is probably one of the most well-studied models for people with serious mental illness. There are about 50 or so published empirical studies and several systematic reviews of ACT. Nearly all of them indicate some degree of improved community integration for ACT service recipients, But the most consistent and robust are these four right here. So decreased hospital use, which has also been kind of a reason that many states have brought ACT teams in to kind of reduce that reliance on state hospital services and inpatient service use, more independent living and housing stability, retention and treatment, sort of that assertive approach to ensure that the people aren't kind of falling through the cracks in the community, but rather there's that outreach and engagement component. And then there's a small number of studies, but the ones that did look at it found that there was adequate client and family satisfaction as well with the model. Where we have kind of more moderate or mixed outcomes are in the areas of reduced psychiatric symptoms and improved quality of life. And I think, again, we don't talk about psychiatric symptoms as much with this population, particularly for folks who have really had many trials of medications that just have not worked as effectively for them. So we think more about functioning kind of in spite of the symptoms. So I think there's been less of a tendency to kind of focus on psychiatric symptoms anyway, while important, still maybe thinking about those other things. And then quality of life is always a little bit of a challenging one because, for one, it's been harder to kind of measure in the field. However, I think the ones that we're really kind of wanting to target and to improve are the areas where we do have weaker research evidence. So that's in employment, improving psychosocial functioning, reducing substance use, and criminal justice system involvement. And again, these I think really point to, and you'll hear as we talk about sort of next steps, kind of focusing on, targeting these particular outcomes. So if we're focusing on employment outcomes, we should be integrating the evidence-based practices within ACT that target sustained employment and competitive employment, or we should be focusing on sort of social skills or psychosocial functioning, focusing on sort of integrated stage-wise treatment for dealing with substance use, and then aligning all the training and the support and consultation that we provide to teams, aligning it with those areas. And then also, and we'll talk about this a little bit later, but the way that we measure it and kind of hold teams to those outcomes by way of sort of our measurement of fidelity. This last one is a little bit more complex, I think, in terms of criminal justice system involvement. And this is by no means to say that all people with criminal justice system involvement should be moved to a forensic ACT team. That's not what I'm saying at all. But I do think it does point to the need to partner with the system in more comprehensive ways, which is what those FACT models really do. And they often will embed someone within the criminal justice system into the ACT team. And so really figuring out better sort of what FACT teams look like and making those sort of more available to people who experience criminal justice system involvement, since that has been challenging for more kind of standard ACT teams. Research on cost effectiveness shows that ACT is cost effective when services are targeted to people who are high service users of inpatient psychiatric services. So again, those that have had more than 50 hospital days in the prior year versus people that haven't had a lot of hospitalization. And those numbers work out better when you're taking a lot of the funding within the system by way of using multiple inpatient services. Also finding that it is more cost effective when it's implemented with high fidelity to the model. So some of the things I talked about earlier, and again, we've really had to kind of revamp what fidelity looks like in order to sort of better achieve that cost effectiveness. And more recently, Domino and colleagues found that cost effectiveness is also greater within ACT within the first 2 years of admission to the program. And I think that probably ties to some extent to the fact that they previously had multiple hospitalizations before being admitted into the program. So that's a little bit about outcomes, and we'll come back to that in a minute, kind of thinking about sort of where do we go for the future and helping to help people kind of live their best lives within ACT and doing that within the team. But essentially what we found is that ACT kind of started as this, program in Madison, Wisconsin, and over a number of years sort of grew into more of an essential cornerstone in our continuum of care today. So not only did the National Alliance on Mental Illness have a big push and have been a big proponent of ACT, they also partnered with Debbie Allness and some of the original PACT program developers to publish the first national ACT standards and the manual. In 2009, the Schizophrenia Patient Outcomes Research Team, or PORT, recommended ACT within the system of care for people experiencing schizophrenia. Many states are required to implement ACT as a less restrictive alternative to institutional settings after the US Department of Justice, per Olmstead versus LC, found them to be in violation of individual rights. Also in 2016, kind of more recently, President Obama signed the 21st Century Cures Act, which prioritizes ACT within a landmark plan for mental health system reform. And over the past few years, the Substance Abuse and Mental Health Services Administration convened 2 expert panels. In fact, Gary and I were on one of those together on ACT. And after a long hiatus, administered grants for ACT implementation for the first time in many years. They also continue to support the online ACT implementation toolkits as well. And we see ACT kind of, in many parts of the world. It may look a little bit different, but it's still very much a part of sort of that continuum of care in other countries as well. So let's talk a little bit about those challenges within ACT. And I think I tried to kind of highlight or sort of foreshadow some of those in talking about sort of where we've lacked in the outcome area. So there are a lot of misconceptions of ACT, as I said earlier. There again are as much sort of a sense that it is really primarily a case management model. You could even like Google it right now or do a literature search on it, and you would find it sort of described as a case management model versus, again, a mechanism by which many services are delivered, including case management. So kind of, again, sort of that focus more on sort of doing for versus teaching people the skills to do more for themselves. There's also sort of this misconception that everyone on the team is a generalist. So even though they have different titles or specific roles, that for the most part, they're interchangeable. And that has kind of led to sort of a watering down of more of a specialization or specialist kind of approach to ACT, wherein specific team members are really sort of targeting or spearheading the implementation of different evidence-based practices that then target those very outcomes that we haven't been so good at. So I'll often tell the story of going to a state and listening in on their daily team meeting. I think I was doing some training, or maybe it was a Fidelity review, I can't remember. But in listening in on their daily team meeting, what was striking to me is that I couldn't tell who was who in terms of different roles on the team. And while that's a good thing in terms of, really working together as a team and people jumping in and taking over for where other people are, that sort of thoughtful need to really sort of target specific areas of practice, and then having and promoting sort of a culture of kind of cross-training, being able to sort of ensure that if I'm the co-occurring disorder specialist, that everyone on the team sort of understands harm reduction or understands sort of stages of change, and that we're not undermining each other, and we're really supporting each other's work in that area, but not sort of assume that everybody does everything, because often what happens is that nobody does sort of that specific targeted work in the team because there's that sense of sort of interchangeability of those roles. So that's really key. Obviously, in the name, assertive community treatment, that's important. I mean, to ensure that people are, able to connect with, loved ones and natural supports and jobs and school and, with services and being able to kind of, again, engage in services, but again, not to misunderstand that as sort of the need to really be heavy-handed. I recall going to one state where they talked about, that we just automatically put everyone on payee Shipp. And that was kind of the first place that they wanted, that they needed to go, rather than sort of individualizing that. There are going to be some people that need payee Shipp, but not everybody. So just thinking in those ways around kind of how we're sort of, again, individualizing the care and keeping that assertiveness as a focus, but not going into this sort of coercion kind of corner. There's also this notion that ACT is time unlimited. And that came out of kind of many years of thinking about, just the fact that we don't want to set arbitrary timelines for when people served by ACT teams sort of receive those services, that they're going to, be forced to sort of leave too soon or before they're ready. And at the same time, what that is sort of perpetuated is this idea that people are served within ACT teams for the rest of their lives, or that there isn't a sense of sort of transition to less intensive services or graduation. And as I said earlier, I think this kind of fits with that first point, which is that, that teaching of skills and helping people to kind of live more independently and work more independently, that those are very much tied together in terms of thinking about kind of how, where people can go from ACT, that it doesn't have to be sort of, the next place that they, live, work, and breathe, but that there's something after ACT. And we'll talk later about sort of how the service system, of course, needs to also be supportive of that, and that there needs to be other services around ACT to be able to support that graduation. But again, coming back to sort of this need to keep working back toward, these are those weaker, especially those first three that I mentioned, these weaker areas of outcome where we haven't really made as much of an impact within ACT. And that in order to do that, we need to kind of debunk these misconceptions and specifically target our services and practices and training and support and fidelity assessment and implementation support in ways that really help to support, so that, as one client once said, a home, a job, and a date on Saturday night. That's what he wanted, right? And gosh, that sounds really great to me too, especially right now in the middle of COVID. But again, that's something that many of us want. And so why would we want to assume anything different for the people that we serve within ACT teams? That really needs to be the focus. And that's certainly kind of a big area of my work and work of Gary and other colleagues that have been supporting this work within ACT teams. Some of the other challenges have been around implementation. So, many of the people that we serve within ACT teams face increasingly complex challenges that actually we hadn't seen as much of before. So I can't tell you, even in the last, many years that I've been working with teams in Washington State, we hear a lot more about methamphetamine. We have, higher potency of cannabis and kind of more readily available to folks, and knowing kind of what the impact can be, particularly when you're experiencing psychotic symptoms, it can be really challenging. We're also in a housing crisis. We have so much homelessness and people who are housing insecure that lack of sort of affordable housing is making it really challenging. And I think all of these things sort of create kind of a recipe for more justice system involvement, unfortunately. And so again, that complexity can be really challenging to sort of have a model be a one size fits all to, help people in all of those ways. And even without that, it's a complex program model, right? There are many different moving parts. When I showed you that kind of figure earlier that sort of showed treatment and rehabilitation and support and, outreach and crisis services and everything that's sort of embedded in there. And then I also said, and by the way, what's exciting about this is that these things change over time, and we're learning more and more what is helpful to people, and there are new treatments being tested all the time to help people who are served by ACT, and that's exciting. And at the same time, that does make it more challenging to implement as a result. And so with that, it means it does require a skilled workforce that can really be responsive to that evolution. Also, that it doesn't operate in a service system vacuum, right? That there need to be other places, other services, other supports, whether it's housing or partnership with kind of, within the justice system. There need to be sort of, a step down process, right? So like when people ask, how long should people be served in ACT? I always say, it depends if like there's going to be a step down from ACT or if it's a fall down to the next service. And if it's a fall down, they're going to be served within ACT longer before they're able to kind of get to that other place that help them to, continue on in a way that is a natural transition. And it's not cheap, right? So there is a benefit, cost effectiveness data for ACT, and at the same time, that doesn't mean that it doesn't take a chunk of change to support it, right? And we need the funding to invest in its success going forward. So let's talk a little bit about the solutions. And I apologize, I know the cartoon here is a little blurry, but I think it's a good illustration of kind of where we're going with the solutions. And that's why I put possible solutions, because I don't pretend to have all the answers here. We're just trying the best we can to kind of figure this out. But I think it's going to take more than just one solution, right? The simple but wrong answer sort of that's the direction that I think a lot of people go. And we have to kind of go in this harder direction of like complex, but it's the right thing. And it's probably more complex in terms of how we address the complexity of the situation. So there have been a number of articles and studies that have been written that kind of focus on these key ingredients for implementing and sustaining high fidelity ACT practice. And again, that includes many of the things I talked about just a bit ago, sort of that adequately funding it within the system. And I would say financing it as well, like having a bundled rate, for example, is a much easier situation for teams that aren't having to feel like they're nickeled and dimed for every single service that they're delivering within ACT, but that they're covered for some of the things that are typically non-billable within a team-based model. Having that sort of championship and leadership at the state level, and even at the federal level, but certainly at the state and in the community, within agencies, it all kind of trickles down, and having everybody sort of having that sort of evidence-based approach and knowing that this is the right thing to do. Obviously, ongoing training and consultation, and I think those are best done by entities that are embedded within sort of the communities or in the states that they're at, so they're not sort of, they're not reliant on a trainer that has to travel, between, let's say, Seattle and Pennsylvania or other states to do it, but that there's a place, for them to kind of continue to support it locally. Ongoing fidelity assessment, we'll talk a little bit about what that fidelity assessment can look like. Potential certification, just to sort of have some specifics on kind of which teams are kind of hitting what we know is ACT and which ones need more help, and again, tying training and consultation to that. And then having the system be, again, ACT is not in a vacuum. There need to be other service options available in the area to support it. And I love this quote. I won't read it out loud to you, but just, for your future reference, that Hella Torning, who leads the ACT Institute for New York State, and Lisa Dixon recently wrote an article about the challenge of optimizing ACT. And, they get into, like, we need to leverage what we're learning within implementation science. There's a lot that we can know and sort of understanding what we're learning through implementation science to be able to be responsive to many of these challenges that we're hearing within ACT. And just one example, this is actually one of my favorites, is the Greg Aaron's exploration, preparation, implementation, and sustainment, or EPIS framework. But you can see here, there's a lot to it, right? There's a lot to sort of supporting and helping prepare and sustain and implement a practice over time that is beyond just having good trainers or having a good workforce or investing in it. All of these different factors sort of go together, and that's, I think, again, where I said earlier, sort of the complex answer is probably the right one here in terms of better supporting ACT. So kind of to shift a little bit into sort of the focus of my work and some of the work that Gary and I have also done together are these kind of thinking about two converging roads to a solution. One is to kind of think about improving integration of other evidence-based practices, and I'll talk a little bit about illness management and recovery, or IMR, as one mechanism to do that. But we see lots of different other examples that are currently being done, such as CBT-informed care, CBT for psychosis, integration of the IPS model for supported employment, integrated treatment for dual disorders, just to name a few. And then the other direction is also enhancing the ACT Fidelity tool so that we can better sort of assess and know if teams are kind of at least on target to hit those outcomes over time that we haven't been as effective as meeting. So let's see, I just want to check my time here to make sure I'm on point. Okay. So one example of that is a program, or I should say a grant that Gary Morse and I were co-PIs on, where we integrated IMR, illness management recovery, within ACT. So IMR is a manualized wellness management intervention. They utilize educational, motivational, and cognitive behavioral teaching strategies. And you can see right in front of you kind of what the different modules entail. We actually piloted this within a number of agencies in the St. Louis area, including Places for People, several years ago, and trained 2 to 3 IMR specialists per team, where they offered kind of group and individual IMR. And again, the idea here was that IMR had been effective in the particular outcome areas that ACT had not. And so it made sense that there was sort of this synergy between the 2 models to kind of merge them together in a way that, you know, helped to sort of improve outcomes in psychosocial functioning in particular, but also looking at other important areas as well. And so what we found, and again, this was a kind of smaller research and development grant, it's called an R34 through NIMH, but we found that implementing IMR within ACT was feasible and acceptable to those who were piloting it. And it was also associated with promising client level outcomes, including what we call medium effect sizes at the 12-month follow-up on clinician-rated illness self-management. So these are the team members who are rating the extent to which the people served in the program were able to manage their illness, manage their symptoms, and all that came with having a mental illness, and kind of how they were doing that. As well as psychosocial functioning. And both of those favored the ACT plus IMR condition over kind of more standard ACT, where they didn't implement IMR at all. And we found some other effects for other outcomes, such as global functioning and symptoms, but they were a little smaller, but still favored in the right direction of ACT plus IMR. So it was a smaller study. It was, you know, low powered. We also had some implementation challenges, which I'll talk about in a bit, but I think it points to some promise, right? Some promise of going in the direction that we want to go to in terms of specifying who does what within a team, establishing roles, and figuring out together kind of where can we go to improve and to help people to achieve for themselves the outcomes that they most deserve and that they want for themselves, right? Similarly, we had a qualitative study as part of that, and I won't get into all the findings in great detail, but again, we just found this to be a positive fit between the 2 models and the people served in the program. We heard many positive examples, and I'll share a couple of quotes with you here in a minute, of people served by the team, but also the team members just really enjoying kind of learning a new approach and seeing the benefit of the work that they were doing with the people served and the people within the program, the clients in the program, talking about sort of how much they were learning themselves or improving in areas that they, you know, were goals for them. Every person has their own personal recovery goal as a part of this model. And, you know, we're able to kind of move toward that in significant ways. And again, those individual level outcomes, while we maybe didn't see it as much in sort of the data, just hearing these rich quotes was just so heartwarming. So here's one that I just want to share with you. It's given me a little hope for the future. For the last few years, I've always been depressed and just kind of stayed in the house. I wouldn't do anything, but now it's brought a lot of things out of me that I know I can do and I can accomplish. Or this person, now that I am doing these things the right way and I am doing what I need to be doing and what I want to be doing, I am less stressed out. So that means less anxiety attacks, less medicines. So it's good. So again, those kinds of things that, you know, the date on Saturday night kinds of outcomes that we hope to achieve. And again, we did experience some significant implementation barriers, which, you know, honestly align quite a bit with what we see in ACT implementation too. So we're learning a lot about, okay, we need to better integrate and be flexible with kind of how we're sort of thinking about how these models work within the context of ACT, and a lot of kind of proactive engagement with the people served, because this was a really different way of doing things than what they were used to with this particular kind of manualized approach and the specific groups and that kind of thing. So, you know, it takes some time to kind of get these things rolling, but certainly seeing some promise in that particular approach. The other area, as I mentioned earlier, is kind of thinking about enhancing the Fidelity tool. So just a quick background on that. So again, I've kind of been throwing around this term, but I should probably properly define it. So program fidelity, for those of you who don't know, is the extent to which a program adheres to the intended model. That's sort of there's a lot of different parts of fidelity, but that's sort of the general definition of it. And I think sort of we're working under the assumption, and this is not just true within ACT, but it's true within other practices as well, for the most part, is that we do know, kind of looking at lots of different models out there, that the higher the fidelity to that particular model, including ACT, often leads to better outcomes. And again, earlier we talked about those outcomes and the ones that have worked really well with ACT, and knowing that there are some that we haven't met the mark with. So again, bringing that into the measurement of the tool. And unfortunately, the original ACT fidelity tool, the DAX, didn't identify a lot of sort of those targets to kind of provide a pathway for teams to kind of know, what the services should be, or what their role should be within the team, to then focus on those outcomes, to improve those outcomes. The focus was more on kind of how many team members or which team members, so that structure of the team, but not the process or the services necessarily. And there were some pretty significant measurement gaps as well. It just wasn't as sensitive. So teams could score pretty highly. So on a scale of 1 to 5, kind of hit a 4 pretty easily, but then not see a lot of change over time. Which again is not, it's supposed to be helpful, right? You're supposed to get some of this information and do something with it, and tie it to hopefully a blueprint to training and implementation support. And when you don't have that information, it's kind of keeps everybody's hands tied in terms of where to go. So what we did is we enhanced the DAX, and it was really great to have the DAX there to work from. We didn't have to reinvent the wheel. It was already, the structure was already there, and we just added and enhanced a number of items. So we went from 28 items to 47, and it examines about 120 or so elements of ACT, rated across a 5-point anchored scale from 1, which represents either not implemented well or not fully implemented, to 5, which is sort of high fidelity. And then assesses structural features of the team, like staffing, kind of who they're serving, level of care, types of services, that kind of thing, but also the quality of care. So, our team members able to operate within their areas of specialty, as I talked about earlier, instead of interchangeably. Are team members knowledgeable and skilled in psychosocial evidence-based practices, or are they focusing on kind of person-centered treatment and promoting self-determination and independence? So we ask those questions within the tool and directly assess it. And so we've got kind of these 6 subscales, the largest kind of focusing on more that sort of structure and operational aspect of ACT, but then 2 that really get at sort of not only the staffing or the structure, but also kind of who does what on the team, like really defining sort of what does the peer specialist do, or what does the team leader do? What are the specific areas of practice or support and supervision they should be providing? And then we also looked at, we've got 2 subscales, one that focuses on, it's called core practices, sort of the hallmark of ACT, the kinds of things you would assume an ACT team would provide kind of at base level, like psychiatric services or case management or high service frequency and intensity. But then we added more specificity around integration of other evidence-based practices that again target those outcomes that we most want to see within ACT. And then also added more around person-centered planning and practices to directly address, where there has been more kind of heavy-handedness around some ACT practices related to kind of how sort of, they can sometimes be in some places. So really kind of directly targeting them. Here's just kind of an example for the first subscale, operations and structure, sort of what that looks like. And you can see kind of 1 to 5, and then there's a whole protocol that's really long and very heavy. It can be a nice doorstop if you ever get a chance to look at one someday. But again, just sort of to give you a look and feel of it. Here's an example of one of the items that focuses on the role of the co-occurring disorder specialist in treatment, for example. And I kind of switched this, the 1 to 5 kind of went horizontally, so this is vertically, but you get the point here, sort of, the most services they're providing that really focuses on a range of, outreach and motivational interviewing techniques and cognitive behavioral approaches and relapse prevention, and sort of ensuring that it's tied to the person's stage of change. That's kind of the goal here within that one item. And so just briefly, what we found, this is pretty early data early on when we first piloted the TMAC, but I think it resonates in terms of seeing sort of similar approaches in other states where we've rolled out the TMAC, which we've got about 16 or 17 states now where they're using the TMAC regularly. But what we found in Washington, just looking at sort of, these are total scale scores, but the average between 1 and 5 across those 47 items and across all the DAX items, you can see here a couple of different patterns. One is, so we've got the DAX in purple and the TMAC in blue. The DAX, right out of the gate, teams did pretty well. And then they kind of maintain that over time. This is kind of what I was telling you earlier about, it just doesn't give you a lot of information. Like, it's great, you can probably feel really good about it, but also because it's not measuring some of those areas that we know are also important to be targeting, so that we can get those outcomes that will be most helpful to people served in the program, it's not terribly sensitive, right? Whereas the TMAC, yes, they scored a little lower, but they did show some improvement over time. We see sort of, hopefully the benefit of training and consultation and the kinds of things we talked about earlier, but that there's more sensitivity in the measure that hopefully gives more specificity to trainers and those who are going to implement the program going forward. Similarly, we've looked at across, we have data on 7 states kind of early on with 144 ACT teams, and we kind of see something similar if we look at the subscale. So these first 3, operations and structure, core team, and core practices, these are the ones that are kind of, quote unquote, a little bit easier to get, that kind of most align with the DAX, but are kind of more foundational, right? And then these are harder. These are harder to achieve, sort of the specialist roles and implementation of other evidence-based practices and person-centered planning and practices. But what it does do is it gives us information. So because these aren't as high, we wouldn't expect to get the outcomes in those areas that would be affected by those practices if they were in place. So really kind of, again, aligning sort of what we're doing with what we intend to see in terms of outcomes. So kind of quick summary here on that is just that higher program fidelity with the TMAC in particular has been associated with fewer hospital days and crisis stabilization unit days. So kind of pretty similar to what we've seen with the outcomes related to hospitalization, similarly around local hospital admissions and fewer crisis stabilization days. But that third one is one that we're really going to keep looking at. And that is that we've also seen that the higher the TMAC score, we've had higher client retention rates and higher competitive employment rates. And that's pretty significant. It's important. Again, these are associated, right? These are correlations, so they're not causal. But I think the important thing in here is sort of seeing, okay, we're hoping that we're kind of bumping things in the right direction to be able to target those particular outcomes over time. If we keep trying, we keep kind of moving that ball up the hill, or the rock up the hill, in true Sisyphean fashion, to get to where we need to go. Incidentally, I just also wanted to point out that in a number of states, including in Washington and Lorna and North Carolina, we've also trained, in a couple of other states as well, trained team members to be co-reviewers or secondary reviewers with us. And so through that, you can see in North Carolina, they've primarily been team leaders and program managers, but in Washington, we have a range, because we don't have that many teams, we have to go beyond team leaders. So we go with kind of who the team leader designates as a potential person in their team that can then get trained as a fidelity reviewer. And then they go out with us and assess other teams. And by doing that, what we've seen is, and again, this isn't a big study or anything, but we surveyed them and learned that, for one, they liked it. I mean, I think it was beyond getting out of the office or getting out of, direct service provision, but that there are a number of things they reported that by doing this, by learning the Fidelity tool and the Fidelity methods and actually going out and seeing other teams, they were able to learn about ACT in a really different way. And so kind of leveraging that a bit in terms of like, that's another avenue, that's another creative way that we can potentially kind of, you know, still do the Fidelity reviews and have them be feasible, and at the same time kind of provide some training as part of that process as well. And so, you know, we are still kind of the lead reviewers. We don't expect them to write the reports. It's just a lot to ask for, but they contribute to them, and they, you know, help divvy up the work of the 2-day Fidelity review and that kind of thing. All right, so I'm going to shift my last few minutes here into just some brief touch on ACT challenges and successes specific to the COVID-19 pandemic. I just spilled on myself here a little bit. Trying to keep myself awake in these last few minutes of the presentation. So this is just a few examples. I'm sure many of you out there, especially if you're working with ACT teams, you could probably name many, many more. But this is from a group of teams that we surveyed across the country who, you know, were willing to share kind of what has been most challenging for them. And I think kind of the bottom line is that COVID has presented a myriad of challenges for both the people served by ACT teams, but also for the ACT team members. And, you know, of course, given that transactional relationship here, the one affects the other and vice versa. So many of what you'll see here is also affecting team members as well. But I can't underscore more the fact that this pandemic has exacerbated challenges for all of us that were already present pre-pandemic. So I think it's particularly true, though, for those who are most vulnerable and most disenfranchised in our communities, and that includes the very people we serve within ACT. It's been very challenging for a lot of folks, and I know many of you are probably nodding your heads as you know you've experienced it. So just kind of to summarize a few of these, social isolation and you know, just loneliness, which is already a real challenge for the people we serve within ACT, has been much harder. And even for those who are living in congregate living facilities or experiencing street homelessness, just the sheer public health risks of either being in closer proximity to others or being exposed in those ways have been really challenging. Meeting basic needs. So, you know, I said earlier, and I made a big point of it, I made a stink of it, honestly, that, you know, teams do more than directly providing, you know, X, Y, and Z and the case management. We need to go beyond that. But you know what happened during COVID is that a lot of people had a lot of basic needs. And so what we did see was a lot more case management, a lot more sort of meeting of those basic needs. And that was important. We needed to do that. That's our job, right? Limited access to phones and technology was another one that was real challenging. That transfer to and from the hospital, and even early on, I think many teams were trying not to have to hospitalize or to have people admitted to the hospital so that they could save beds in their community, and that had a whole host of challenges associated with it. The sheer symptoms that people experience. People shared stories of, you know, several people that they worked with who either had pretty significant anxiety to begin with, and that this just only exacerbated it more, or paranoia. And so they would have more difficulty with reinforcing public health practices, or, you know, concerns about where COVID came from, or some of the misinformation or disinformation out there that has just kind of perpetuated some of that, I think has been really challenging for folks as well. Substance use, you know, again, we see this in the general public, that substance use and mental health, you know, symptoms have both increased, and it's certainly been the case for many of the people that we work with as well. This is also a population that experiences more medical comorbidities. You know, what data show that even pre-COVID, that this is a group of folks who died an average of 25 or so years earlier than their friends who didn't experience a mental illness. And so, you know, add this terrible virus to it, and, you know, multiple underlying conditions, and that has just been super challenging. And then fewer community services and support. So the things that were the lifeline in the communities, either shrinking or not as available, especially early on, again, when we didn't really know what was going on with COVID. Remember when we were like disinfecting all of our surfaces, and we didn't even know if we could, like, you know, hand off any materials, or they had to like sit, you know, for 3 days. I mean, all of that. But even without that, and just knowing sort of food banks are just, there are so many people in need that then that just means that there's less for the people we serve who have often relied on the services before COVID, and now certainly, now that it's here. So those are just a few. And again, I'm sure that there are many, many others that people could add to this list. As I said, challenges for the teams, just go back to that last slide, because those are also hard for the team as well, because they're the ones really helping to navigate that. Early on in particular, I think that consistent access to PPE was a real challenge. And what we heard is in some states where there was a prioritization, and with something like ACT, where you're out there in the community, almost like a first line of, defense as a frontline worker, and yet not getting the same prioritization as others who would have been out medically and being exposed in the same way. I know in our state, we were like the 4th level to get PPE back when, that it was really limited. And so that was a real challenge. And just reinforcing public health guidelines across the board within teams. Again, you have to all be on the same page and reinforcing the same things, and not all team members necessarily being on the same page, or not all, people served, clients served in the teams. That steep learning curve to telehealth, and I think this also kind of overlaps with just the lack of technology for some of the people we're serving. And what we're finding is, some teams were able to get smartphones, and that was really great, but not everyone could use them really well. But we're learning kind of how some teams have been able to do that well. But it's, not everything is exactly as it was just because we've got telehealth and smartphones in some cases. That changing up of scheduling and rotations, teams kind of need to be sort of a well-oiled machine around this stuff. And that just got flipped on its head with COVID, because there was a lot more sort of trying to reduce exposure among team members, with each other, with multiple clients. We hear a lot of burnout, a lot of compassion fatigue. I think it's pretty notable that recently SAMHSA prioritized supplemental funding for training to promote provider well-being within their mental health technology transfer network, with ACT teams, again, having access to that free training as well. And I'll share a slide that kind of has that information on it for others to have. But strategies and successes too. We heard a lot of great stories about kind of what teams were doing, and we're still better understanding. I can't say that these are all like best practices, because we're still learning, but just, again, really reinforcing and teaching strong public health practices. Many teams kind of talked about needing to take more of an occupational therapy approach to kind of breaking down what some of those guidelines are, and really using that in the way that they were teaching skills and working with people served on the team. Kind of ramping up direct provision of basic needs. As I said earlier, we heard lots of good examples of just how they were kind of partnering with food banks or preparing food boxes. Lots of care packages. We heard great examples of those, whether it was care packages that included kind of more sort of public health related materials like, masks and gloves, or, hand sanitizer, that kind of thing, but also like creative activities that they were individually tailoring for the people who were at home more, and just, trying to have sort of things for them to be able to do and keep their attention, and, try to take their mind off what was happening. Pretty common theme, but not a one size fits all approach by this at all, but just this minimizing exposure to kind of figure out, we used to do it this way, and now we have to shift. And so some teams, for example, would have like a small 2 or 3 people who would take like a 14-day rotation where they were still going out into the community and, doing it as safely as possible with PPE and adhering to public health guidelines, but then, self-quarantining. Other teams would talk about they had a number of older team members or those with underlying conditions who they needed to kind of shift out of the going out in the community at all. And, some agencies just, decided that they weren't going to do any in-person at all, especially earlier on. And so the teams were among those. So they had to figure out other strategies to engage. And I think just that normalizing of fears and validating frustrations of the people they were serving, being as consistent as possible. Lots of conversations about just increasing communication, even if it was brief, and just being really flexible in kind of how they were doing things, and just trying to keep people oriented to, I know we did it this way before, but now we're doing it this way because of COVID. I mentioned earlier just the phones, the data plans, and then just partnering with others in the community, making use of community giving. We had some places for people, several presenters a couple of months back on our national ACT calls talking about sort of how they were kind of partnering with community agencies in various important ways. And, we had lots of good examples too in a recent call before the holidays about how they work with churches around gift giving, or, working with certificates, grocery certificates through various funds, and just in ways that they hadn't before, getting really creative about this stuff, to just kind of maximize in a time that is really challenging for the people they're serving, right? Even more so. And so we're still learning about this. We have kind of shifted and have recommended that instead of doing quote unquote fidelity reviews right now, to shift to something called quality reviews, just because they're, in most cases, those that have done the reviews have not been able to necessarily access the same data that they did in the past. So it's kind of compromised from that perspective, but also just that teams are just doing things differently right now. And so, and for good reason, but what would be high fidelity, for example, multiple face-to-face contacts, that might look a little different, or they might not be hitting those marks, or 75% of services delivered in the community. That's that's not safe. And so really trying to kind of shore that up in a way that still allows us to kind of get a sense of how teams are doing and collect some information on what kinds of, practices they are doing during COVID, but not also having them on the hook with scores that don't really reflect, they reflect COVID, they reflect how they were doing during COVID, but not necessarily during non-pandemic times, which is what the point was of the Fidelity review. But I'm curious, will teleconferencing and telehealth stick? Are there creative approaches that we'll continue to do within ACT? Are we able to work, smarter, not harder with ACT? And again, what are the implications for Fidelity? I don't know the answers to these questions, but I think they're really important ones that we're going to be keeping our eye on going forward. And so just with that, I'm about to shift gears, and I apologize, I'm running a little bit behind here because I know we have a panel, but I just wanted to share with you all, we do have these monthly and quarterly national ACT calls. The monthly calls are for anyone who works within an ACT team or supports an ACT team, and the quarterly calls are for anyone who is like a funder or trainer or fidelity reviewer, or an administrator. So it's kind of more sort of higher level sort of systems focused. And then we also have colleagues, Lynette Studer and Mimi Choi Brown, who are launching a team leader series. In fact, the next one is on February 8th. And so there are links there to be able to register for those going forward. And then I just wanted to say, that we're going to be learning a lot. We just got some funding, Lorna Moser and I and colleagues Lynette Studer and Gary Cuddyback, to do kind of the first comprehensive study of ACT across the US. So it's to be able to help guide policy and practice going forward. So a national survey to just get a sense of many of these questions I've kind of got listed here, because we don't know the answers to them. We don't even know, this is going to surprise you, but we don't even know how many ACT teams are out there. And those that call themselves ACT, what do they do, or what do they look like? And so that's what part of the focus is on. But the second has been to be able to kind of define some practice benchmarks and be able to kind of look at the relationship between fidelity and outcomes in those states that do have those data, so that we can, just again, better guide sort of where we're going around resource devoted to ACT going forward. We're also going to be automating the Team Act, so people won't be carrying around that big binder anymore. And some of the data will actually already be in there already, that teams report. So we're hoping it'll be a little bit more facile. And then lastly, I just want to put a plug in for, adaptation is great. Don't get me wrong, there's a lot of important adaptations that need to be made, but we also really need to be focusing on just enhancing existing ACT. And many states don't have enough ACT, and they don't have access to great ACT. And so focusing on kind of more enhancing specialization within the teams in like core areas. I think trauma is another big one that we really need to be figuring out better, and integrated healthcare as well. And then thinking of then specialization, as kind of a different thing, and still very important, but I would probably zero in on some some specific areas, such as kind of what does it look like within rural areas? Could we leverage some of these models that they've, used in the Netherlands and in Scandinavia called Flexible Act, or the other fact, as we call it, or forensic services within ACT, and then transition age youth. And again, we are kind of limited on data, and for each of those, it does mean you're integrating different practices within them. And so it does make it more complicated, but still very important to be focusing on, but just not shifting everything to an adaptation, but like, what can we do to really enhance the current ACT model? And so with that, I will transition out. Thank you for your patience as I went about, I think, 10 minutes over. I apologize, but I really appreciate everyone's attention, and I'm really excited to kind of hear what your questions are and to talk with our panel who are doing this work on the ground. Thank you.
Maria, thank you. That was wonderful. It was comprehensive and thoughtful, and it was great to be able to cover both some of the kind of basics, but also the cutting edge issues that are going on today and pandemic related, and also the future. And you did that again with your good cheer and humility. And I liked your cartoon, by the way, about the solutions there with the fork in the road. That was funny. So I know we'll get back to you with some more questions and comments and reactions. But before we go further, we'd like to do a virtual thanks to Maria for maybe about 15 seconds or so, if we could all give her a virtual clap or cheer. And Kara, is there a way to be able to bring everybody up full screen where we can do that? So
unfortunately, we can't bring everybody, but I'm sure hopefully you can feel everybody's vibes. I mean, everybody can definitely chat in the chat, that's for sure. And I'll give you a nice clap too.
Well, and I gotta say, I meant to say this kind of right out of the gate, but just the gratitude I have for the teams. If there are any teams out there that are on for today, just the really important work that all of you are doing. You guys deserve all the applause. So thank you. I know it's hard right now, especially.
Well, Maria, thank you again. And I hope you can feel the appreciation and the gratitude people had for your really, again, wonderful and fun presentation. And we will bring you back in a little bit, but right now what we wanted to do was be able to get some responses from a panel, and we've been able to assemble a panel of really thoughtful people bringing some diverse perspectives. What I'll do is introduce them one by one as each person speaks, but in general, what we were asking of the panelists would be if they would give first any kind of general reactions to your presentation or any of the points that you brought up, and then secondly, if they had anything they wanted to share from their perspective about the challenges about ACT Fidelity under the pandemic, or if they wanted to say anything just about major benefits or challenges about ACT to staff or to persons served. All that we've kind of asked people to do within 5 minutes. So I know that's kind of a tall order and a challenge, but we'll look forward to whatever people can share within 5 minutes about any general reactions or challenges or benefits. And first, I wanted to be able to introduce Peggy Stark. And Peggy really comes to us bringing that very important perspective of a ACT team leader, which is critically important, but not so easy sometimes, but can be a very rewarding job. And Peggy has worked for over 12 years as a licensed clinical social worker in outpatient and community mental health settings, and starting in 2014 that she helped the Compass Health Network, which is one of the large systems in Missouri, to launch their first ACT team. So Peggy, thank you for joining us, and look forward to hearing whatever thoughts you want to be able to share with us within about the next 5 minutes.
All right. Well, thank you, Gary. I appreciate it very much. And I want to reflect what you shared with Dr. Monroe-DeVita, is that your presentation was a breath of fresh air. Sometimes when we're stuck in the trenches and working with clients who are really struggling today, it's very easy to kind of lose sight of the impact that we have on people. And that's one of the things that I love and I thrive on about conferences like this, is that you actually get to see and hear perspectives of other people and remember the whys. Why do we do this? Why does it matter? Why does adherence to the core model and the Fidelity make a difference? And that's one of the things that was a huge refresher to me and that I greatly appreciate about this. In general, one of the strongest reactions that I had, and I was taking notes during your presentation, and the one that I wrote down 3 different times was the excitement about the idea of having co-reviewers. That's something that's very new and foreign to me. And I think, especially for teams that are kind of distant from one another, teams that we have a strong connection with our local or our state departments of mental health, but we don't necessarily have that boots on the ground kind of connection with the other teams. I think that would be a great way to kind of take a team that is maybe doing well, but not doing great, and helping them to really see the difference in the way the services are provided and how that can help take it to the next level. My particular team is in Nevada, Missouri, which is a smaller, more rural community. The population of Nevada is about 8,000 people. It was the location of one of the former Missouri state hospitals. So we do have a pretty, for a small community, we have a rather large proportion of individuals with severe mental illness. And all of these challenges that you addressed are amplified even more when you're working in a small town. Even though we're considered like a rural ACT team, we still only function within our own county. We don't branch out to long distances like some of the truly rural teams do. But a lot of these areas that you identified on the challenges for people that we serve have been amplified even more. For example, not only do we have limited access to phones and technology, we have limited access to service, to data service, to even be able to use video technology. We have limited access to things like transportation. So the people who normally were relying on various types of public transportation or the team member to help them access things like medical care, grocery stores, to pay their housing deposits, to access utility assistance. We had to get really creative in how you approach that stuff. So it just takes the basic fundamentals and amplifies it even more so. The other area that we found that was particularly difficult for us, and I don't believe that this is necessarily just a rural community thing, but it ties back to that core idea that ACT is not just case management. It ties into how can we truly demonstrate, model, show people how to function when you're doing things over the phone or by video. How can I truly show them, how to sort and wash their dishes, how to complete an application, how to have a conversation with their next door neighbor when I can't be with them while they do it. And we have seen such an increase in isolation and struggles with basic daily functioning since COVID, the last several months, specifically as a result of those things. So one of the things to me that is probably the most important thing is that remembering to keep, we are advocates for our clients. We are passionate in the community, with the community resources, with landlords, with other kinds of partnerships, whether we're talking law enforcement, probation, the mental health court types of systems. We're advocates with them, but we also need to be advocates within our own agency to make sure that The agency understands and partners with you to be able to be creative in coming up with ways to continue to implement pretty close to Fidelity, even in these strange times. And I see that I'm almost out of time. So, but those are just some of the things that came up in my mind as we talked, concerns that I've heard from, various ACT teams across the state when we've had our meetings. And those are the challenges that I see right now for these programs. So thank you so much.
Peggy, thank you. We appreciate you sharing those important thoughts. And again, the work that you do every day, which is so critically important. And I'd also like to introduce the next person on our panel who probably has the most important role of any of us in ACT, and that is as a person who receives services from ACT teams. Chandra is a person with lived experience, including with services from ACT teams, and she's currently a member of the Places for People Consumer Advisory Board. So we're very fortunate to have Chandra with us, and welcome. We look forward to any thoughts you'd like to share with us in the next 5 minutes, Chandra.
Okay, thanks, Dr. Gary. My experience with the ACT Act 1 team, I've been with them since like 2011. Wouldn't trade for nothing in the world. And they helped me build confidence in myself, where I'm able to speak for other clients as far as, meet the client's need. I speak for them, I'm an advocate for the clients. And they just helped me, come a long way. Because at first I had no self-esteem. I had low self-esteem. Now my self-esteem is so high that I love my team. I wouldn't trade for nothing in the world. So that's basically all I have to say, though.
Well, that's critically important. And thank you, Chandra, for sharing those thoughts and just for your own journey and everything you've done in your own life. And as you recover and as you share your experience and your wisdom that comes from all that. So appreciate you being here. Thank you so much.
Thank you, Chandra.
Thank you.
Our third person who's on the panel is somebody that I've had the opportunity to work with on an ACT team. I became a staff member of an ACT team in fall of 1989, I believe, Don Shipp. And over that time, in the past 31 years, Don has had a number of roles, particularly on ACT teams, multiple staff positions there. He's been a team leader. He's also done work on homeless outreach teams, including as a supervisor. And he's been the team leader in the past of 2 different ACT teams. For the past 2.5 years, I believe, Don has also been the program manager of the 4 ACT teams at Places for People. And Don brings a wealth of experience and also a really big heart and a sense of humor to match the size of that heart, I think. So we're fortunate to have Don with us. Don, I'd like to turn it over to you.
Hi. I'm not sure if anybody can hear me.
We can hear you.
Okay, perfect. Thank you. Thanks, Gary. Thanks, everyone. Sandra, you look taller on TV. That's awesome. I was like, Maria, I wanted to say too that I really thought it'd be a tremendous value for our teammates to be able to go out and do Fidelity reviews, kind of like Peggy was excited. I locked onto that too. Like, I feel like they would just learn so much and get a better understanding, a deeper dive. Oh, this is what it looks like. And just kind of like, until you teach something, you really don't know it. But when you have to teach it, you really just learn it. So I was very excited about what you're doing out there and would love it if Lori Norval could get on the stick and have that happen in Missouri. It'd be awesome. So ACT practitioners are just movers and shakers and dynamic. And since COVID started, we're asking them, we're just having a hard time keeping team members and bringing new team members on. And they get on here and it's like, what kind of job am I doing? Did this say telemarketer? Am I a telemarketer now? I'm supposed to be out doing it to it. And so I'm looking forward to getting back, but this has really been hard on us and causing tremendous turnover. And it's really hard to hire people. And when we do hire people, it's hard to onboard them. It's like Sandra, the way we were able to connect with Chandra is by being in her face and her being in our face. And she got to know and trust us. We got to know and have hope and be inspired by her. One of our peer support specialists, he's now a case manager, but he started out as a peer support specialist for us. He was saying that, Don, I'm hardwired to trip in areas like this with the election stuff that folks went through, and the BLM that we had. Also, you put COVID and you put all these other things on that causing our businesses to be boarded up. And if we're isolating because of our psychiatric condition, and we're seeing all this boarded up and all this mayhem and destruction on TV, and we don't have access to our case managers, it's really just a tremendous turmoil. So I just wanted to stress that there is that COVID is bigger than I could even think. And I commend all the workers that just, not giving up and just doing their best. Hopefully the vaccines will be out and we'll be ripping and running out there soon. So that what I was nurtured in my teams is that team cohesion that I always felt. So I know teams are trying to do everything they can for Zoom, connection and whatnot, but they're really, for me, there's not much of a substitute for being, in the presence of others. So I just find that a challenge. I just, I'm so proud of everybody that's just making the best go of it that they can. So that's all I wanted to share. Thank you, guys.
Thank you, Don. And I think, those are really good points too about some of the difficulties the pandemic causes for staff too, and the difficulty retaining people and hiring people. And it, just adds a lot of turbulence to already important but challenging positions. At this point, I'd like to introduce our fourth and final person on the panel, Lori Norville. And Lori has 31 years of experience in mental health, and the last 10 or so of those has been within sort of community treatment, as she's worked for the Missouri Department of Mental Health in their Fidelity review section, where she's currently the manager of evidence-based services and reviews. And Lori, I think that also this is just an opportunity for those of us who've worked with you over the years to thank you for the way you've done those Fidelity reviews. I think you really have done them in the spirit that Maria has intended the TMAC to be used, of not only kind of a very thorough review, but you've really done that in a collaborative way of helping teams then to be able to kind of look at their strengths, but also look at areas of improvement and providing a lot of good ideas about how teams can improve in the process of how to do that. So we're glad you're doing the good work that you are with the state, and look forward to anything you'd like to share with us about general reactions to Maria's presentation, or challenges for ACT under the pandemic, or any other benefits or challenges about ACT.
Well, thank you. It's good to see you guys. Hi, Maria. It's been a long time. Gary, good to see you. Dawn, as always. Peggy. There's a lot I could say, but I don't want to take all the time up here and do that. One thing I will say is that when the pandemic started, there was a lot of panic, a lot of concern about what's going to happen for our persons served. But I wasn't worried about the ACT teams, because ACT teams are ideally equipped to handle these kinds of things. They're transdisciplinary. The team works so closely together. I knew there would be logistic problems, but they've worked through a lot of those. So I just have to say, and I can't say this enough, that I'm so proud of how our teams have really continued to provide quality services through the pandemic, and they really, really have. A couple of reactions that I had. I love the idea of co-reviewers, and I've tried to recruit some team leaders as reviewers already. So this is the second best thing. If I can't get them to come work for the state, we will see if we can't, because we have some phenomenal team leaders here in our state, just phenomenal. They could be Fidelity reviewers with no question, no question. So I'm going to get on that real fast. Also, Maria, I was looking at the different barriers, and I had talked with my review team about what are we seeing from the perspective of Fidelity reviews that are obviously barriers or things that the teams are struggling with. And everything that you listed on the slide, that's absolutely true. Just learning technology, being isolated, fatigue. A lot of the clients are expressing, you know, fatigue about not face-to-face, not being face-to-face. We also are noticing a difference in the way that we interact directly with the natural supports and family members. I mean, our teams would go in and bump into people's loved ones in the home or their communities. And since we've been so restricted, you know, with those types of face-to-face visits, we're having to do exceptionally more assertive engagement with families and natural supporters. So that's one area. Also, our teams, you know, they do outreach. They're very much outreach experts, but that's been on like times 1,000 with COVID. Our teams are doing a lot more meeting immediate needs, but also outreach engagement and re-engagement. Here in Missouri, we have a number of specialized ACT teams. We have FACT, we have ACT-A, we also have teams that are for disability, DD, and then some that are just ACT teams that serve only individuals that also have co-occurring diagnosis. And we also have a specialized women and children teams now. So a lot of different needs kind of come to the surface with some of those specialized teams during COVID. But the teams have done phenomenal work to try to stay engaged, provide those evidence-based services, meet the basic needs, and continue to help people be able to graduate from ACT services to something less intensive. We've continued to do that through COVID, and I'm very excited that Missouri, you know, has been able to keep moving forward with those services. So we will continue to do that. And I think the presentation also, Maria, I was just thinking that it sounds so much like the presentation we give to new ACT teams or agencies interested in starting ACT. And so we learned from the best and have continued that forward here in our state. And so I'm thankful that we got that direct training in the beginning on just how to do ACT and how to use the Fidelity tool. So thank you, Maria, and we're very proud of being able to get that from you directly. So that's basically all I have today. So thank you for the opportunity.
Thank you, Laura. I appreciate you sharing your thoughts and your expertise. And I think that was particularly important what you said about not only the stresses and the challenges that are there for ACT teams and staff, but the resilience they've shown to be able to still go forward and provide the best services under really difficult situations. So thank you for your comments. If we could put everybody back up on the screen, we would do another kind of virtual clap, but I'm sure people are channeling that kind of positive energy. So thank everybody on the panel, and please stay online there as we go to a question and answer. And with that, I want to introduce Julie Blanco, who's the Director of Training. And Julie is, you might have seen, we've had quite a few chat comments and questions during the presentation. So I think Julie has been attending those and thinking about those, so she might be able to pose some questions that have come in chat, or people can bring up new questions. And the other just kind of quick thought is, I know Maria, you've kind of listened to some of the panel presentations, so I think we'd also invite you to have an open mic to anything that you might want to say in relationship to anything that came up in the panel. But I also like to go ahead and transfer over to Julie, who will take it from here.
Thank you, Gary. So we had one question that came in, and I don't know, Maria, if you know any details about if there's a lot of research on VIMR, or I guess that's IMR specific to, like, with the employment module.
There is one called EIMR. I wonder if that's what, it's enhanced IMR, and it basically takes, it integrates what we know is true for working with people with co-occurring substance use disorders, and integrates it into the IMR modules so that it's a more integrated approach for folks who are experiencing both.
Mm-hmm.
And so it's right now in the process of being kind of disseminated more, you know, it's limited dissemination, I would say, right now, but the University of Minnesota has been doing a lot of that training and a lot of that information. I can actually put in the chat specifics on kind of where they could find the information for it, but I wonder if that's what, unless they're talking about V meaning virtual IMR.
Oh, maybe that's what, it was the employment person that asked that question. So that may be why I assumed they meant vocational. So virtual IMR, maybe that's what.
And if it is virtual, I mean, I think we're trying to figure that out. You know, teams it was variable in terms of teams, you know, feeling like groups were an easy transition or not, partially because of the things we were talking about. Like if they didn't have access to more than just, you know, regular tracker phone or whatever, you know, and then smartphones were more challenging, or access to other data plans or Wi-Fi, you know, all the other things that need to be in place. So I think that has been more challenging. And so, you know, group-based, I think, has been harder, but also people have shared successes there. It's kind of been a mix. And then if they were doing IMR in a group, you know, that would be affected. Doing it individually, I think, you know, could be. I know we've also heard, and I didn't share this as kind of one of the specifics, but I know teams talking a lot more about just more focus on like relapse prevention, kind of, you know, we're actually going to, one of our topics for our National Act calls is going to be on facilitating the app that the SMI advisor developed on My Crisis Plan, which is basically a psychiatric advance directive that then rolls into each state's requirements. And so just teaching the teams about that particular resource for relapse prevention is part of IMR as well. So.
All right. And, you know, in the chat, I've seen Colleen, who is our IMR expert here at Places for People, said that there, I guess, is a vocational IMR. So I don't know if Kara or somebody, if Colleen is willing to say anything about that, if Kara wants to make her a panelist. In the meantime, while we're working on that, I can ask you about the idea of co-reviewers, both as the value, like what have you seen as the value add for teams being able to really get that exposure to what other teams are doing and bring back, and like that sort of, is that the biggest benefit that's been happening, or
yeah, it's a great question. So maybe I can just share too a little bit more specificity about what it is. So we started with team leaders and kind of program managers who provide support to team leaders, and then just quickly in Washington just needed to extend beyond that because we only have so many teams. But so now team leaders will say, I want these two people to now do, you know, Fidelity reviews. You know, I can't do it anymore, or I'm already trained or whatever. But the benefits that people have talked about have been, for one, just to go through the Team Act, like, you know, in a real deep dive in the way they do, because we have to develop consensus ratings with them in the same way we do for, you know, any Fidelity review. And even though they're not the lead reviewers, we try to take the burden off of them for a lot of the logistics and the, you know, as I said earlier, the report writing and all of that, the planning with the team and that. But just that fear, that just kind of deeper dive into the team and then seeing how that looks when you go see a team. And so teams have actually talked about, or co-reviewers have talked about, like, they could actually go to a team that's not doing very well and just see and learn from it. You know, just the sheer learning of like, okay, I get it. Or like seeing things that are happening and saying, you know what, I think we're doing that. And I don't think I realized we were doing that, but that's hard, or that, you know, or I'm learning from this, or, so I think that has been really interesting. And then certainly seeing teams that are doing really well as well, and being able to be like, whoa, like we've heard a lot of examples of people, you know, stealing from each other, like different ideas or different tools, just because you get exposed to all that, especially when you're doing them live and in person, you just get that opportunity. And in some of our larger teams, we actually have 2 reviewers. So there are 2 people from 2 different teams going to see, you know, a third team. And so they get to kind of meet someone else from another team and kind of bond with them. And I will say, I mean, they benefited from it, but we benefit from it too, because we just learn so much from them, having an eye on the teams in a way that we do not. Like, we have several of our reviewers that did work in ACT teams, but it's been years. And so just to have that fresh perspective of like people that are like working within the team, and, you know, so that's been really cool.
One other thing, this is for Maria, but also any of the other panelists, this idea of how ACT has been thought of as case management, and ACT providers, you know, as case managers versus like the specialists and really strong clinicians. And what are your thoughts on the best way to get over that sort of bias or dismissal of, you know, this like highly clinical, challenging service as like just case management?
I'd love to hear what other people's thoughts are. I mean, just the ones that come to mind for me is, I think, you know, we see it in our smaller teams, it's more challenging than in our larger ones. And I think that's partially because there is a lot of crossover in terms of roles, because there's only so many team members. And so I think, you know, it's hard to carve out that time to focus on that particular specialization. And I think in some teams, that's just how they're funded. They're not, this is where I go back to the funding piece, you know, like if you're not funded in a way that's going to support people really being able to kind of focus on a particular role, because you just don't have the bandwidth, you know, there are just only so many people that can do, you know, all of the different pieces, then that just becomes, you know, much more challenging. I think the other thing is we have to get smarter about how we train about it. Like, I think I've been trying to think more about like competencies, like if we just train everybody in CBT informed care, and then that translates to all sorts of things, right? Like some team members can take that and go focus on co-occurring, and some team members can take that and apply it to, you know, employment. There's just so much. Similarly, like motivational interviewing, like I think there's just some core competencies that I think just naturally translate into many of these other practices that could really help to kind of grow that in a easier way and embed it kind of right out of the gate, like when they get startup training, you know.
Did any of the other panelists have anything about that idea or that question?
Yeah, I'll mention that the role training for us here when we start teams or even bring a new ACT team member on board is key. We do a training, DMH offers a training specifically to that member on their role, and it includes additional evidence-based practice training. We ensure that agencies hire qualified people in those positions, and some of those can be challenging to hire, the employment specialist, the COD specialist. So we pay a lot of attention to ensuring that they are qualified, that they understand their role when they come on the team, and that they are given, you know, free opportunities to receive that training on their evidence-based practices that they use in their role. And that has really helped us, I think, to maintain it's like you know, it's known that ACT is not just case management in Missouri. I don't know that we've had as much of that, but that's what we try to do at the state level.
Thank you, Lori.
Yeah, I want to jump in here real quick also. I think both what Maria and Lori said is very true, but I think it goes back to the very beginning, the interview process and actually hiring the right person. Finding a person who has not only the specialty or the background that will be an asset to that area, but a person who is a true team player. Because I have experienced on my own team times when you had parallel workers who were working side by side, but who were not truly working as a team. And that can be another very sticky situation on an ACT program, because we want to have people who are specialized and understand their evidence-based practice role. But if they're not good team players, it can be toxic for your program. So I just wanted to make sure I threw that little piece of information in there. One of the things I have done is I have stepped in and I am either interviewing or actively involved in all of the hiring on my team. I no longer allow that to be handed off to human resources, because I'll get somebody who's qualified on paper, but somebody who's not a good fit personality-wise or from a team perspective-wise for my program and for my group of staff. So.
Great, thank you so much for throwing that in. We had another question come in from, I'm going to call you out, Tim McKay, who's an OT and a team leader at Places for People on one of our ACT teams. And he asked Maria, I'm going to read it to you. So first, do you have any recommendations for possible research topics centered around OT and ACT and how they could be implemented together? There is another OT here at Places for People on Tim's team. And I was curious the steps that we would need to happen, that would need to happen for OT to be an identified specialty within ACT. You know, and that OT really does enhance ACT and could really spearhead those areas of skill improvement and functioning. And I second that, because I've worked on ACT teams with OTs, and as a social worker, I have learned so much from OTs. It's been amazing. So yeah. All right, Maria, there you go.
No, I saw that the question in there, and I was hoping I'd get a chance to answer it live, because I agree. I couldn't agree with you more. And interestingly, so I don't think, Gary, you probably know this, but the very first PACT program actually had OTs on them. And I think what happened nationally is that my understanding is that like each state's a little different in terms of scope of practice and how much they're focused on mental health, but that there was kind of a less of a connection to mental health services with OT sort of over the years. But that really, I mean, you can see why that was the case, because of exactly your points, is that there's just so much there. And when we think of all the things, when we talk about like psychiatric rehabilitation and skills training and all of those elements, like that is like, you know, it's in some ways, it's a little bit of a foreign or different way. We're almost retraining so much of the workforce when that's actually naturally what OTs do, and is sort of their training, you know, that is their training, that is your expertise anyway. But some states have focused on OT. So for example, there are more OTs in, for example, Oregon, and they also have them in their early psychosis, their first episode teams, their ESIT programs there, kind of serving in a similar role. And I was going to put something else in the chat too. I can't remember what it was, but I'll try to remember. But I'll also put in the chat the information. Actually, Lorna Moser has somebody who's working with her who is an OT, who they're actually targeting specifically this particular area, and they just wrote a grant, which didn't get funded, but I don't think it's gone away. It's just this idea exactly, you know, that you're saying, to really embed OTs within ACT teams.
Yeah. And we had another question come in about thoughts about other therapies, like music therapy, for instance.
Yeah, I mean, I think I don't know the evidence around music therapies and those kinds of things. I think that we're learning a lot about, I mean, you know, I think to kind of the earlier point that we're we're learning where there are other ways for people to learn, to enjoy, to focus on specific skills. And I think, there's just so much. I feel like that COVID is like, laid bare as far as, whether it's music or, meditation or daily activity or, just the kinds of things that at the same time, like sometimes we can get so focused on evidence-based practices or these higher, things that are like, take a lot of training. And then it's like, but all of these other things, like, what about them? I feel like it's kind of also laid bare some of those needs and the importance of them for everyone, and so there's, I think, a need to kind of balance those two things and recognize that it's not this or that, but it's sort of a true kind of integration of both.
Thank you. And there's another question that I think could be for any of the panelists, but it says, can you address how ACT teams describe the impact of working on recovery, and how can this be instilled to other treatment modalities as well?
I'll tackle it. But feel free to hop in, Maria. There's a lot of the ACT teams are using different curriculums and strategies that promote recovery, RAP, IMR, different personalized methods of helping someone discover what is their recovery path look like, and how can the ACT team members help them get there. And so I think it's a wonderful model. There's just different things that teams can do. Somebody mentioned music therapy, there's art therapy. So we help those individuals serve to understand, what does recovery mean to them? Not just what does the ACT team say recovery is supposed to be for me, but what does it look like for me? And where do I want to be 3 years from now? That's where they start. It's that meeting them where they're at, and it's also stage matching the types of interventions that are provided. And then just helping that individual walk that walk to go into their recovery and hopefully continue on that path. So there's a lot of different ways to do it, different curriculums to use, different strategies and approaches by the team. Motivational interviewing is another best practice approach that's absolutely key to helping someone discover, what's my recovery supposed to look like? What do I want it to look like? And I think that ACT has actually caused in some agencies those methods to bleed over into some of the traditional case management and therapy strategies that are not part of ACT. I think I've seen, at least what I notice is that I see them popping up in other types of programs, like the outpatient case management, ITCD that we do here in Missouri. I see these things, EIMR, RAP, wellness strategies, motivational interviewing are key evidence-based and curriculums that are being used. So I think there's some bleed over from ACT, which is good. That's exciting.
Thank you. And then we have another question about the best skills and the best practices for certified peer specialists on an ACT team. So I don't know who wants to take that. I mean, I think it's such an important role, but I think it's one that's not always used to its greatest strength. So what thoughts do you guys have on the best use of peer specialists in ACT teams?
One of the things that I shared when I was back, kind of going back to hiring my employees, when I hired my most recent peer specialist, one of the discussions we had early on was, I need for you to be the voice of the client in every aspect. And that goes not only from helping the client to identify their own voice, but also keeping the rest of the team on task with remembering that the client is the driver of their service, that the client is the one who gets to determine what their recovery looks like, that the client is the one that we need to always be their advocate and not let the rest of the team accidentally slip into that bad client role, or that if only they would have done this, something wouldn't have happened or would have happened differently. And from a team perspective, from the functioning of the team, to me, that's one of the most important pieces. There are lots of other things as far as the client interaction, RAP, IMR, helping them identify what their goals are, et cetera. But I think as the team lead and from the functioning of my team, the most important thing that peer needs to do is to be the advocate and the voice of that client within the team.
Any other thoughts on that question? They're all important, but that feels like a particularly important one.
Maybe I can just say, because I agree with what both of you said, and just maybe adding like what we're hoping they're not doing, which is, that they're not needing to be the ones who are doing all the case management or the transportation or the kinds of things that are not that it's sort of a supplement. I mean, we see that a lot, is that like there's a part-time role and it's part-time case manager and part-time peer specialist or something like that. And I just think it goes back to what we were saying earlier about then it's really hard to then, it's just like if that person was the employment specialist and they were the case manager but I think it's even worse because it's this sort of like, it's the go-to somehow, or it becomes the default, like, oh, this is what we're going to do within the team, versus like, no, this is somebody who has this lived experience that is so important and so specialized in its own right that we need to protect and focus on that particular role in the same way we would protect and focus on any other role within the team. So just to kind of, also say what it should not be. I have a tendency to do that, I realize. So
I would just add on to that, Peggy. One of the things that we do here in Missouri is we have networking calls across the different ACT staff. All the peers that are ACT peers get together every month for a networking phone call. Now we're doing it web-based, and we talk about their role and their experiences, and we do some training in those calls. We problem solve, we brainstorm, and so it preserves the idea for the peer specialists. They know that they are specialists. They're not case managers. And I think that those networking calls really give them the opportunity to refresh themselves. That yes, we're professionals with a set of evidence-based practices that we use, advocacy, the voice of the client. And so we really protect the role of the peer and the other roles on the team and promote that by the use of the networking calls. So
great, thank you guys so much. So I think that brings us right to about 1:55. So we're on schedule for being able to kind of wrap up. I want to thank everybody for being here. I want to thank our panelists. Thank you, Maria, for that great presentation, and for all our panelists for your input. That was so helpful. I want to remind you about upcoming events. We have another webinar next month on February 11th. That's Thursday at 1 o'clock, and that will be on evidence-based practices in substance use treatment, with a special focus on community reinforcement family training, CRAFT. That will be Dr. Robert Myers, who is the developer of CRAFT. So we really hope that you can make it to that one. Please look for announcements about that webinar. And please remember to complete the post-training survey. I believe that Kizzy just put that in the chat box. So please copy and paste that and do that survey for us, so that we can get feedback on how we're doing and what we can do better. And thank you so much, everybody, for being here. And Kara, I think you had something to add.
Yeah, I just wanted to remind everybody that if they needed CEUs to fill out the CEU survey, or if you had any issues, feel free to email me. I'm sure you've gotten an email from me at some point throughout this whole process. And yeah, fill out that survey. We also sent out the slides a couple hours before this happened. We are recording this as well, so we'll be sending out a recording along with those slides. We also sent out some resources, some contact information of panelists and some articles and some other videos for you all to look over. We don't want your learning to stop here. So if you all have any questions, please let us know or contact the panelists on that resource guide. If you're wanting any more trainings or just information, that's kind of what we're hoping to help you all out with, because like we said, we don't want you all to stop here with what you're looking for. So please let us know if there's anything else that you all need. But we really appreciate you all coming out today, and have a great day.
Thank you for sponsoring it, Places for People.
Yes,
Appreciate it.
thank you.
Thank you
Yeah,
so
cool program. Great panel. Thank you.
Yeah, thank you, our panelists, and to Maria. We really appreciate it.
It was a great job. Thanks everyone so much.
Thank you, everyone.
Be safe. Be well.
Take care.
Bye-bye.
Bye.